I will tease this by first asking you, so where's Dustin Hoffman during all this? I think that is really the important thing that we need to know about the coronavirus and COVID is where is Dustin Hoffman?
Dustin Hoffman. All right.
Yeah.
You're going over my head with pop culture stuff.
I'm going to get you. So we'll come around to my Dennis Hoffman take.
Dustin
Hoffman.
Yeah. All right. Lay it on me.
No. I got to wait for that. So I decided we're going to come up with more COVID segments. Oh. I'm inundated with questions. I'm getting emails, things that people want to know. I'm like, I'm going to go to the Outbreak guy.
I'll give it a shot.
So here we go. So I try to articulate a lot of the questions the best I can. The first and most important one, I think, is a valid one, is testing. I know I had a conversation with you offline. We talked about they were really moving forward with a whole lot of tests quickly. Some things don't feel like they were really vetted properly. There's a lot of reports. The media is loving the sensationalism of all of this. Where are we on the validity of tests? Which ones work or don't work? Are there certain things we could say to our testing facility or our doctor or nurse about a test that we would want, something like that? And then also not only detection, but also antibody.
Yeah. Well, I mean, there are those two distinct types of tests, right? You have the tests looking for the genetic material, and the method that most people are using is reverse transcriptase polymerase chain reaction, RT-PCR. And when they stick that swab up your nostril, that's the test that we're going to do. And that's a pretty good test. It's highly sensitive. So if you do come back with a positive on that, you're pretty much locked in. You were positive.
So PCR testing.
PCR, yeah.
Okay.
And then there's other types of nucleic acid tests that are out there, which are pretty good also, and they're really better for the high throughput. Cranking out these samples, the Quest, the LabCorp type style. And that's a nucleic acid methodology, but it's not strictly PCR. There's antigen test out there. Antigen is just like a protein produced by the organism.
So people aren't going to understand what these things mean. So let me make sure I go dumb it down even a step further. So you mentioned the PCR testing. So is that the long swab or the short swab? Or does it make a difference?
Well, it can be either, because they can do the long wire swab up in. Yeah. That's the nasopharyngeal.
Yeah, that's the one that people are like really like make sure eyes water because they'll really dig in there.
Yeah, and that's probably the best sample, because we may talk about viral load, but the nasopharyngeal part of the body is where the highest viral load is.
Okay.
Yeah.
All right.
But they also can do throat swabs and oral swabs and stuff like that too.
Okay. So you're going to the other one, which is more of an antigen.
Yeah, there's antigen test out there, but I haven't heard anything good about any of them yet. So, so antigen test is probably not the way to go until they get everything ironed out. And then, of course, the antibody test. The antibody test is going to be a blood test. And they're looking for, when you get infected, your body's going to produce antibody. Right. Hopefully it's protective antibody, but it's going to produce antibody. And about 14 days after your infection, that's about the soonest, you'll start producing something called IgG antibody. And that'll get stronger over time. But you really can't use that for diagnostic purposes, right? It's not a diagnostic test. It's more of a surveillance and were you exposed type of test. So those are the ones out there. But if you're going to get tested to determine if you have COVID-19, it's going to be one of the PCR nucleic acid type tests. Yeah.
All right, and most of those are having. What's the percentage on false positive negatives? Do we really know?
Well, with any kind of lab test, there's all this pre-analytical stuff you have to concern yourself with. So if I go up there to take a nasopharyngeal swab from you and I don't collect that properly, you could get a false negative. That's possible, right? So it really has to go all the way up there. So proper collection, proper transport, right? It's got to be put into the appropriate viral transport media. Other issues with it would be timing. I think timing is a big issue, and they had a recent study from Johns Hopkins. So basically, when you're first infected, I think most experts at this point say it's about 5 days till symptoms.
Okay.
Yeah, it's about 5 plus or minus whatever, but it's about 5 days. So if you have a sample collected that day you thought you got exposed or the day after, whatever, it's pretty much going to be close to 100% that it's not going to come up positive. So you'll get a false negative.
You just don't really have much in there to
Right.
detect, basically.
You got to give it some time. So the percentage of false negatives is very high, like within the first couple days, and then very high, like toward day 9 and 10, like that. So there's kind of a window.
And that would be when the virus is coming back down again.
Yeah.
In I guess quantity,
We're
right?
talking about days 9 and 10.
Right.
Yeah.
So think of it like a bell curve. Early on, you don't have much. You've been exposed. It's going to reproduce in your body, make a bunch of viruses. You have some, then it kind of comes back down again.
I've seen recommendations. The best time is about 2 to 3 days after symptoms.
Okay.
But if you're asymptomatic, which
You don't know. Right.
So it would be 2 to 3 days, after that 5 days after exposure.
Gotcha.
Yeah. So that's kind of the ballpark out there. And that's, as far as anything else on testing?
No, I think we're good. But you mentioned viral load, so let's go right to that, because there's a lot of. First, explain what viral load is and means. I know we just talked about bell curve, so I guess kind of correlate what viral load kind of means, and then kind of help the people understand what we're kind of talking about here.
Well, viral load became kind of a everyday topic when HIV was out. So they would test the blood sample for viral load to determine if a person's getting better, if the viral load was dropping like that. Well, the viral load is essentially the amount of virus or the organism in a sample.
Okay.
So your nasopharyngeal swab would be a certain viral load. What does that mean? Well, that's really up in the air. We've seen a lot of people have said, well, the higher the viral load, the more severe the disease.
Sure.
Intuitively, that makes sense.
Right.
However, with this virus, various studies have been showing different things. Interesting study out of Italy showed when they were at the height of it that the viral load in asymptomatic patients was the same as in symptomatic patients.
Right.
So that kind of throws out the what you would think is normal, right? And they had similar studies in China, but then there was other studies in China where it was, very definitively the high viral load meant higher, more serious infection. Okay. Which is what you've been.
That would be what we would expect.
Natural thing, yeah. So I guess the answer to that right now is the results are inconclusive. That we just don't know exactly. Then there's the infective dose, and that's the amount of virus it takes for you to get an infection. So so
that's not viral load; it's infective dose,
right?
Okay.
So if I was positive and I coughed and it went over to you, how many viral particles does it take for you to get an infection?
Right.
And I don't think there's a number. I don't think there's a number to that yet either.
Right. And every person would be different.
Yeah.
In some degree, right? Because you would have, one virus versus 10 versus 100 versus 1,000.
Yeah.
Right.
Yeah. And again, the problem is they really can't, to determine the viral loads, they would have to do like studies on human beings. So they would have to infect you with certain amounts, and clearly that would be...
Yeah, to quantify all this is really, really difficult.
Well, and you're talking about an extremely pathogenic organism, so it's...
Sure.
You can't do that.
Yeah.
That'd be like, say, hey, let's do a test on a human
where you could die.
With anthrax.
Yeah, where you could die.
Yeah.
Right.
So, that's just...
it's not going to happen.
What's the word? It's unethical, right?
Definitely.
You just can't do it. Infective dose... What else did I want to tell you about that? Oh, and the other thing, as far as the pathology... The interesting thing about this organism in pathology is not necessarily how much you get, how much of the virus you get, but how your body reacts to it. And we kind of talked about this on a previous program. So if I'm immunocompromised, I can get infected. My immune system is underreacting. The virus is going to do what? It's going to invade cells, multiply, burst, invade more cells, and you can get a severe infection. Now, opposite to that, you can have a time when you may be infected with only a little, hypothetically, and your immune system is going to go overreact. And we talked about the cytokine storm on previous episodes, and that can happen. That your immune system is going to start fighting your body and destroying, different tissues, which can be serious pathology too. So, you have to consider that with this particular pathogen too.
Okay. So, all right. So let me kind of circle back around a little bit to the bell curve of viral load, that you could have an infective dose factor. We have a whole lot of things. And we're testing people who are already positive. We're trying to determine when they're, I guess, coming out of it. How do we determine? So we have a friend that has someone who's in the hospital, been in hospital now for weeks, really struggling with recovery. They've been tested like 5 times. Of course, they're positive. Yeah. First of all, what is the strategy with testing a positive person that many times? And then we'll get to the reporting of how that even correlates to the data that we see.
Well, early on, that's what they were doing. In order for them to determine that you were negative, they would run tests until it was negative. I don't think that's being done anymore. You become positive, you do your 14 days away, and you're cleared.
Right.
So now this individual is hospitalized. So
they're in ICU. Well, I think they're in ICU, but they're really struggling with recovery. They're definitely in the high risk category. Yeah. Recovery was even, they thought they might lose this person at one point, but just the thought process of them doing that kind of test. Because I know in Italy, one of the reasons that their number of cases was so low is during the peak of this, the hospitals were completely overloaded. You had people in the hallways. They weren't even doing testing. So you came in, you had difficulty breathing, you had the fever. We think you have the symptoms. We treated you as you're positive, and let's move on. They weren't wasting the man hours and the resources to do testing. They just assumed those were positive cases. I don't even know how those got reported, but I know that's how it was being handled. We haven't had really that crisis in America other than some aspects of New York City and Brooklyn and things like that. But that's very small and localized and didn't last long term. So we don't really. And what is do we have anything standard of what testing protocols are in different states? Like, do we even know?
Everybody's following the CDC protocol. So,
okay.
Yeah.
So
it is standard.
So do you get tested? So I guess my question is maybe not expressed well then. So the determination of being tested on day 3 or 5 and I'm positive is, well, we'll test you for positive again, or we won't test you, or 14 days, or is there any real guidelines on how any of that's going to work? Or
with this individual, since he's hospitalized in an ICU, determining whether he turns negative is probably part of is the treatment program working or whatever?
Right.
Is he on the road to recovery? But for the normal person that goes through a drive-through and all that,
I understand that.
Yeah.
Okay, so then. All right, so we don't know that part, and then I wanted to ask a little bit about sort of the more of an opinion. So we're going to go into like philosophy, I guess, for you. So I listened to an interview. Brett Weinstein is, I don't know, is he evolutionary biologist, I think? So
from Evergreen?
Yeah. So he was talking about just the philosophy of shutting down, not shutting down, letting the virus run. And the backbone of his conversation stemmed around how the virus will learn how to spread, learn how to survive. I don't think we think... It's weird how Americans look at viruses. I think it's just odd. You think of things differently because you've been studying this for so long. So the virus has to learn how to get from whatever host organism into a human organism. It has to learn how to spread. It has to do its thing. So now that we've done this, we've gone this many months, we're kind of seeing an uptick because we've had such a massive exposure of human-to-human contact with all this. Where are we at on your thoughts on the timeline of the virus changing, mutating? Is there any way we would even know if we're doing the right things or not? Or how do we know from looking at other coronaviruses or viruses in general? I mean, how do we know?
Well, just viruses in general, we know it's going to mutate. That's what viruses do.
Sure.
So, I mean, we just go ahead and chalk that up right now. And they even have determined that the strain that was in China is different than the one in Europe.
There's an Italy strain and a China strain.
Yeah.
And there was a lot of this early on about a right versus a left, like an R versus L. I think that's what they're talking about. Like the one, I don't know which one's which.
I'm not clear about the exact differences in them.
Well, they're something like they're opposites of one another or something. They basically, so like proteins have L's and R's, so they basically have the same thing. I don't know if it has to do with that ferron receptor or not, but I'm kind of under the impression that maybe that's something that it is. So one is just way more virulent than the other one. That's what we saw in Italy.
Okay, and that's something you're going to see.
And that's what came into America via New York, whereas with California, the one that arrived in California came through China, so we didn't see as much of the spread.
That makes sense.
That's what that's what I'm understanding. I could be wrong, but yeah.
I mean, like we talked the other day, what do male mosquitoes do? Well, they go out to mate. They have, what do viruses do? They mutate, and they're going to. And we see that with influenza every year.
A virus just wants to find a way to survive, right? It's just going to keep making more viruses, right?
Yeah, and it has to. And it's going to continue. It's a intracellular parasite, basically, and it has to have cells to multiply. And without that, it does nothing. It'll survive on here for 48, 72 hours. But after that, it's done. So it goes into cells. Viruses go into cells. Their machinery multiplies. Cells burst, and it goes invades more cells. That's how it works. Yeah.
Okay. All right.
But as far as Brett Weinstein,
it was a conversation. I'm not trying to footnote him as though he's the expert. He just brought it up from a different angle. I really hadn't thought about that. We could obviously some of the scientists, and we heard this, right? We should shut down, right? We could shut everything down. We didn't really factor, then of course the political side of this is more the economical side of, with every unemployed percentage is so many deaths because of the way the system works and the dependency and how our system is very codependent on one another. So I don't know that he was really trying. So he was just more the pure scientist of shutting it down, because when it's out in the open like this, it's going to be way easier to see it change and become something different or whatever.
But I think there is some evidence. There's been some studies that showed that the lockdowns actually made it worse.
That's what I thought.
Yeah. So now I think what he's probably thinking of is, hey, let's do the China method. Lock everybody in. If they don't leave their house, grab them by the hair and put them back in.
Yeah, 3 weeks, right? Yeah, 3 weeks of just shut it down, which, by the way, South Korea basically did as well.
Yeah.
So, but if you tested positive in South Korea, they locked you up. We don't want to treat South Koreans. We want to treat them like they had this great model and it's something we should emulate, because they all masked up right away and they all submitted to roadblock testing. But the moment was, if you were positive, you were locked down like the Chinese. So we need to stop pretending that they were the greatest of models.
Yeah, and that's, I guess that's the point to Brett Weinstein, if that's the point he was making, is this is the United States, and that just won't work, right? And we are seeing numbers rise, right? We saw 9,000 cases yesterday, 9,000. But you also have to remember, state of Florida, 9,000 cases in Florida. And let me be clear. We also did over 70,000 tests, which is like double what we usually do.
I thought it was more than double. I thought we were running about 25,000 tests. So maybe I guess we're
70,000 that one day.
Okay, so that's what I'm saying. So I thought we were running about 25,000 tests per day.
It's around 30 something.
Okay, 30s, so we more than doubled, and we found 9,000.
Right, and I mean, I could speak for Hillsborough County. I know those numbers pretty well. Granted, we've increased about 2,000 cases in the past couple days, which is a lot. So we're about 8,000. But if you look at some of the other numbers, hospitalizations are down to they're less than 600.
Yeah.
So you're talking about 8%, which is not bad. And the fatalities are like 130. So you're talking about 2%.
Yeah, the utilization in a lot of hospitals are still in the neighborhood of between like 25 and 40%. So there's really not much of a hospitalization issue in most areas. Bigger the city, certain hospitals, of course. I don't know. I personally would, if I felt like I was really concerned, I knew there was an issue at my closest hospital, I would drive 20 minutes. In America, there's a hospital pretty much 20 minutes in any big city. You're not going to find another hospital to go to.
Yeah, and I've seen like, for example, the Tampa General numbers. One thing with Tampa General, and I'm assuming other hospitals might do this, is that they test all their employees.
Yeah.
So they've had, 125 employees come up positive.
Sure.
Not all at the same time, but over the period of time. And I think that's a wise thing to do, since they're going to be around patients that are vulnerable.
Well, and they're also at high risk of picking it up because they're exposed to positive patients. So no matter how much PPE you have, eventually, you're eventually probably going to possibly get something.
But those 125 people that were employees that were positive, I mean, they could have contracted it at the beach. They could have been anywhere.
Right. They didn't have to come for work. It's just the fact that they are higher risk.
But if you look at their numbers as far as patients that have died at that hospital, I think it's been 13 for weeks now. It hasn't really changed. So.
Right. Yeah, there are some counties. I looked at one day, I think it was 2 or 3 days ago, Hillsborough lost 2 and Pasco didn't lose any. So like here extremely locally, that shows that these hospitals are not in crisis mode like at all. I'm not saying we won't ever get there. I'm just trying to say in this phase, we're not seeing. The other thing I think, and I saw yesterday, I saw the data breakdown, didn't go to 9,000. We didn't have the new data, but everything amongst this surge of patients, the average age has dropped down into the 30s.
Right.
These are young people between 18 and 45.
Not a big surprise.
So the hospitalization, the ICU beds, they probably won't come into play as much as when we've seen these outbreaks. We've had worse situations break out in Tarpon Springs when it was in an assisted living facility. Right.
Yeah, and it really depends. I mean, we're seeing what we see in Hillsborough County. I understand, I've heard that some hospitals down in South Florida are getting packed to the brim. I don't know how.
Well, they have been overloaded the whole time. Yeah. Like the situation in Miami, Broward, Dade, those areas, they're so compact. Obviously, the population down there, and you have an area where you've had massive protests and rallies of thousands of people getting close together. So there's also, I don't know what their hospitalization numbers have changed. I really haven't looked at those graphs yet, because I'm looking to see, if you want to look at the data for yourself, folks, look at what has changed. Don't just take a raw number. Let's say there's 200 more. Well, that doesn't matter if the patient was able to go home. Maybe they were in the hospital for 8 hours. They were on basically like a nebulizer. They were having some minor treatments, and they send you home. But they didn't require a bed. They didn't require any
hospitalization.
It doesn't count, right? So just because you see these positive cases and you see all this stuff, that doesn't count as hospitalization. It definitely doesn't count as ICU. They may be hospitalized for a day, get fluids, and we know these are standard protocols that were happening in Europe. You mentioned Italy. This was standard protocol. Once things stabilize in these countries, we got lots of information from those doctors. This is what they did. A lot of people would leave after a couple days. That prevents it from being a crisis.
Yeah, I mean, we see very similar things when flu season is ramped up.
Right.
Now, I don't want to compare the two, but you do. If you have a very bad flu, they may hospitalize you, make sure you're hydrated, and let you go.